Hi, PICU RNs. This is Ann Jones. I'm one of the nurses on the PPCU, and I have some education today for you on nasogastric tubes. So one of the objectives here is to identify how to measure an NG tube length for insertion, to describe how the research recommends to verify placement, and to consider signs of tube dislodgement. This education is coming because there's going to be a new policy for enteral tube management coming out at the end of January. Much of this information was included in the pediatric enteral feeding and nutrition policy that is currently available, but there is more information and it's going to be a little easier to find. As always, Lippincott is going to be your go-to for procedures. So in the survey that I sent out, asking about measuring NG tube for placement, there was two options, the NEMU and the NEX method. And like many of us RNs here at UMMC, you guys mostly use the NEX method. And that was your method that used to be taught. But we've actually found in the research that using NEMU, it has a greater likelihood of placing the tube in the correct location in the stomach. So this, instead of just going nose, ear, and xiphoid process, we now lengthen that a little bit and goes nose, ear, and midway between the xiphoid process and the umbilicus. So there's just a little bit extra length to that tube, and it means that it has a little bit better gastric placement. If you're curious about the research on this, Lippincott does use this or recommend or indicate that this is the correct method for measurement and has references for that. Couple of tips and tricks for inserting an NG tube. First of all, you want to make sure that you're choosing the correct size. So the smaller the better, so long as it'll fit in the patient and is long enough to fit for them. You want to go as small as possible. These aren't very comfortable for our patients, especially on insertion. You'll need some tape and tegaderm to secure it down. It's helpful to have a chucks or a bucket because sometimes these kids will throw up when we put the tubes in because it isn't a comfortable procedure for them. But it does help if they swallow while you're inserting the tube. So having a pacifier for the little ones or a drink of something to help them swallow while the tube's being inserted will help. On the PPCU, one of our standard order sets on admission is for lidocaine lube. I'm not sure if you guys have it as well, but it is available at UMMC. It's a lidocaine lube that you can bring into the room, have them place a little bit in their nose if they're older, or put a little bit in whichever nair you're planning on inserting the tube into while you get set up so that it has some time to work. And then that lube can be used on the end of the NG tube with insertion as well. Water is also a perfectly good lubricator that you can use. As far as positioning, infants should be swaddled. Keep their arms away from batting at you. For a small child, it works well often to have the parent sit on the bed, put the child on the parent's lap facing forward, and that way the parent can help hold the child, and it's also a position that feels a little more secure and comfortable for them. The older child should be sitting upright, leaning a little bit forward. With this new policy rollout, there are going to be some changes in EPIC documentation. It should just make it a lot more logical and take out some of the double documentation that there was originally in there. You'll still go to the LDA avatar to click on whichever nair the tube is going into. And some of this is fairly standard, what tube size you're using, what kind of tube it's going to be. But one of the important aspects here is this initial landmark at nairs. I would recommend that you fill this out once the tube has been confirmed to be in the correct location, in case you need to migrate it forward or back a little bit, so that this landmark can be what is going to be the reference landmark. So say you put it in, you measured that nose, ear, and midway to the umbilicus. At 25 centimeters, you put it in, you got your confirmed placement. You'll put 25 here, and the thing that will change now is that in the flow sheets, that 25 centimeter mark is going to show up in the flow sheets for all additional next nurses to be able to see and compare that, so that it's really an easy reference point. So that mark is going to be really important to check each time. And so we don't want to tape over it. It'll be in the flow sheets, and you want to check that what's in the flow sheet is actually what you see at the patient. So you need to be able to see it. So this is an example of very bad taping because there's no tube evident at all. What you want to do is something more like this, where we tape it securely, nice and close to the nair, because you don't want a whole lot of movement there. If it's not taped too close here, what can happen is every time they swallow, that tube moves a little bit, and it can cause skin breakdown on that nair. So you do want to tape it nice and close to the nair, but don't cover up that centimeter mark. You need to be able to read that mark, and all the other nurses will as well. And then you're going to tape along the length of the tube so that there's no little loops for fingers to grab, and that way we can reduce the chances of them pulling it back out. On the survey, I asked how the correct placement is initially determined. And many of you chose auscultation. And I'm not sure if this is how the wording of the question, but the required standard for checking initial placement is an X-ray. This is the gold standard across the literature, that X-ray is your way of checking whether a tube is in the correct place, and it's the only way that is really confirmatory. So anytime you are placing an NG tube for the first time, or if it comes out and you're replacing it, you need to get an X-ray. This means that a provider needs to put an order in for the X-ray. You can call down and ask Portable to come up once that tube is in place. And then the provider needs to read that X-ray and ensure that it does in fact show that the tube is in the correct place. And then finally, for you guys in your location, you, I believe, often get X-rays for other reasons, to check their lungs and vents, I think, intubation. If the patient is getting an X-ray for any other purpose, have the providers reread and make sure that that NG tube, it remains in the correct location. So for ongoing placement, you obviously cannot get an X-ray every time you're going to use the tube. So the evidence, the research recommends using two methods, because none of the methods that we have for checking NG tube placement currently are 100% accurate. So in order to sort of hedge our bets, the recommendation is to use two methods. And you guys are doing a fantastic job at this. 100% of you say that you are already using two methods. So gold star for the PICU. What the two methods could be is, first of all, that really important external marking, which is why we want it in the flow sheets, and we want to be able to see it at the nair so that we can compare the two. That will be your first check. Your second method can be either a respiratory assessment, and this is like ensuring that there are no signs or symptoms of respiratory distress, no coughing, gagging, desaturations, increased work of breathing. The other option is a gastric aspirate, because stomach contents from an empty stomach can look very similar to aspirate that you would get from a lungs. This is best used in those kids, the little babies who have an order to PO first and then gavage. So if you've given the kid 25, they've taken 25 mLs by mouth, and now you're going to gavage the rest of their feed through their NG tube, that would be a time where it'd be really appropriate to aspirate and see if you're getting from the NG tube the same formula that they just PO'd. And if they did, you can be very confident that that tube is in the correct place. What you'll notice is auscultation is not on the list. You guys, like many nurses across the nation, were taught and believe that if you auscultate and listen and hear a whoosh, over the stomach, then the NG tube is in the correct place. But this is not what the research shows. And in fact, 30 years of research has shown that even very experienced nurses are unable to tell if the whoosh they're hearing is coming from the stomach, the small bowel, the esophagus, or most scarily from the lungs. So when we do that auscultation, we may hear the whoosh, but it's not telling us what we think it is. It's not telling us whether the NG tube is in the correct place. And the American Association of Critical Care Nurses called for an immediate discontinuation of this practice back in 2012. And we hear, like many nurses across the nation, have not yet been doing this, but we need to start following what the research says. So you'll notice on the new EPIC documentation that'll roll out in February that you will have, for our ongoing placement verification, 2 options to choose. That external marking, no signs and symptoms of respiratory distress, the characteristics of the aspirate, and again, this will be best used in those little babies who have just PO'd. For you guys, potentially you may have just gotten another x-ray that confirmed placement, but auscultation is not going to be one of the options. If that tube does become dislodged, here are some of the signs that you would see. So you may see apnea, bradycardia, coughing. They might start desatting. There may be a change at that mark. Fear, and you'll notice I italicized this. I had to use F so it would fit in the ABCs. But this fear thing is that, the kid that's just kind of anxious, they're not behaving kind of like themselves. They seem restless and kind of off. And on your differential for why they might be more unsettled needs to be a consideration of whether their NG tube has become dislodged. And then finally, gagging or choking. Now, obviously, all of these symptoms could indicate something else, but if you have a child with an NG tube in place and you see some of these things, one of the things that you need to think about is whether that tube has become dislodged and whether a repeat x-ray is necessary. So how often should we be monitoring placement? It should be done at the beginning of your shift with your patient assessment. If the patient is running continuous feeds, it should be done every 4 hours while that feed is running. And for you guys, since you're doing assessments every 4 hours, it makes sense to link those. And then anytime that you go to use the tube, the NG tube, when it hasn't been used. So if you're going to start a feed, if you need to do a water bolus or a flush, if you're going to give a medication, when you're going to use this tube, you need to check that it's in the right place. And then finally, if the patient has an episode of emesis or severe coughing, we all know those kids who've thrown up their NG tube. So just double check that it is in the right place in those situations. So again, at the beginning of your shift, every 4 hours if they're just running continuously, anytime you go to use it, and if you've had concerns. We've streamlined some of the documentation, taking some of these things that sort of had no reason for being 2 different things and combining them into one, and then adding a couple of other options for our tube feeding that it stopped or completed the feed. Just a couple of notes on medication. We do need to be following the 5 rights of medication administration. So if a med is ordered PO, it needs to be given PO and cannot be given by an NG or a G tube without a change in the order. If your child just recently had a NG tube placed, get the providers to change that medication to an NG administration route. Not all medications can be given via an NG or G tube. Most of them can, so in most cases it's fine, but you do need to have the order changed in order to be following the correct methods. If you have a pill that you need to give via an NG tube, make sure you're mixing it with sterile water. Don't be tempted to use formula or just tap water, because the proteins and chemicals found in those can affect the bioavailability of some of the medications. So if you have a pill, double check with pharmacy that it can be crushed, and then just always use sterile water as the safest option to make sure that you're giving the full dose. Don't be tempted to mix the meds in with a formula bag either. There are some of our kids who have chronic illnesses. The family may put, for instance, their multivitamin into their morning feed. If there is an order to do so, that's fine. But generally, this is not a good practice. You can't be sure they're getting the full dose. It's not getting in over the same amount of time. And as with the previous note, it could change the bioavailability of some medications. As an example, our organ transplant kids who are on tacrolimus, the Prograf, this medication is notorious for sticking to the tubes, and so it cannot be given by an NG or even a G tube with the extension set put on the G tube. If you're going to give it by a G tube, you need to use a slip tip and put that directly into the Mickey button, because it is so interested in sticking to that extension tubing that the patient does not get the full dose, and that is obviously a big problem for these kids. Finally, just to troubleshoot some of the clogs, your best option is to prevent it by flushing after every feed. Usually that flush is going to be water, but in some of the little babies, especially if they have a fluid restriction like the cardiac kids, in the NICU, they will use a small amount of air rather than water to flush. But generally, you're going to use a little bit of sterile water. It doesn't take a lot. The 8 French are primed with like 1 ml. So it's just a little bit just to clear that line and prevent clogging. If you do end up with a clog, warm water is going to be your most effective. I don't know how many of you heard that, Coca-Cola was magic, and if you use some cola, it would take that clog away. Actually, the acid in the cola's drinks can bind with the proteins and make your clog worse. So just put some warm water in, let it sit for a few minutes, and then use a plunger to gently try and declog it. If that doesn't work, there are orders for sodium or pancreatic enzymes that can help with declogging a tube. Just to note that this here, what you're seeing is not a NG tube, it's a Salem sump, it's a Rapogal, and is used primarily for decompressing, so pulling stuff out of the stomach rather than putting it in. They are bigger and more firm tubes. So if your primary intention is to feed through the tube, use an actual NG tube. Don't use the Salem sump. They're just not as comfortable for the patient. And this blue extension here is where the air can enter so that you don't create a vacuum. If it's leaking, don't just put a diaper over it. If it's leaking, it's not working correctly. To fix that, you're going to flush the blue with air and the clear with water. There should be an order in for any patient with a Salem sump to do this every 12 hours with the amount of water and air to use. But it can be also done just if you find this blue tube leaking, you can flush the blue with air and the clear with water, and that should solve your problems. So 3 big takeaways. Don't tape over that mark. We need to be able to see it and make sure that we can check that against the flow sheet that it has not moved. Keep doing what you're doing. Use 2 methods to check for ongoing placement verification, but one of those cannot be auscultation because it isn't telling you anything. It doesn't tell you about where that tube is. We need to use the external mark, and one of the other options, such as a respiratory, making sure there's no signs or symptoms of respiratory distress. These are the references for the research on all of this. If you have any questions, this should have come to you in an email. You're welcome to email me back. I'd be happy to answer any questions that you might have. And have fun with your NG tubes. Thank you.